Hello, everyone. Welcome back to another episode of the Recovery After Stroke podcast. My guest today is Dr. Violiza Inoa, a leading neurologist who spearheaded medical missions in rural Dominican communities before pursuing advanced training in the United States. As an assistant professor at the University of Tennessee, she champions stroke prevention and treatment. Dr. Inoa's expertise in vascular neurology and interventional neuroradiology has earned her numerous accolades, including the Excellence in the Treatment of Acute Ischemic Stroke Award. Before we dive into the interview, I'd like to take a moment to introduce my book, The Unexpected Way That a Stroke Became the Best Thing That Happened: 10 Tools for Recovery and Personal Transformation. It's a collection of inspiring stories from 10 stroke survivors showcasing their incredible journey from adversity to personal growth, covering everything from nutrition and exercise to handling the emotional challenges. This book is a beacon of hope for those on the road to recovery. For more information, you can check out recoveryafterstroke.com/book or simply search for my name, Bill Gasiamis, on Amazon. Dr. Violiza Inoa, welcome to the podcast.
Hi, how are you? Thank you. Thanks for having me.
Thank you for being here. Before we do have that conversation about stroke awareness, stroke prevention, and supporting people during those stages where they're having their stroke or their stroke is occurring, tell me a little bit about yourself and the work that you do.
Of course. So again, my name is Violiza Inoa. I practice stroke and neuro-intervention in Memphis, Tennessee, the United States. I am a neurologist by training, by background, and I dedicate my life to seeing stroke patients for prevention, but also for hyperacute treatments and post-stroke care.
Your work has got you to this stage of your career where you're really encouraging, you want people to know something about stroke. You want them to know that stroke is treatable. And do you have a sense that there is a feeling in the communities that you deal with, or the people from the communities that you deal with, that stroke is not treatable, that it's some kind of a condition that when it occurs, it's devastating and it's life altering and life ending?
Yeah, no, absolutely. And it's not just a feeling. Obviously, I've had my personal experience with that, with many patients that do not recognize stroke as an emergency or as a treatable condition. However, there's a lot of data behind it, data from the community, from different states. We know what is going on. The majority of the Americans nowadays, they know that stroke is an emergency, but if you were to ask if they would call 911, less than half would actually seek emergency treatments. There are many people in the population that would say that they would recognize stroke symptoms, excuse me, but they would not seek any medical help. And the reality of it is that we've lived in a culture where people believe that if they had a stroke, they're doomed, that there's nothing they're going to do about it, that stroke leads to death and disability, and that's it, that there's no opportunity for treatment. And we are here to tell you that that is not true. Stroke is a treatable condition. I think for many years, many of us have spent a lot of our energy in educating the population about stroke prevention. And I think that's absolutely important. Talking about the importance of recognizing high blood pressure and diabetes, high cholesterol, unhealthy lifestyle, treating those conditions in order to prevent heart attacks and stroke. But I think we've spent lesser time in talking about treatments. And the reality is that treatment of a stroke is one of the most impactful treatments in medicine. And we can talk a little bit about what that means in a few minutes.
Thank you for saying what you said. So the whole reason this podcast exists is because there is a gap in the support for people who have had a stroke. And then when I had my hemorrhagic strokes and then I had to have brain surgery and then I had to learn how to walk again and all those things, I didn't have anyone sort of reaching out to say, hey, this is going to be okay. We're going to work it out. You're going to get through that. In 10 years, you're going to be in a better position. Maybe you'll have some physical challenges, but you might have been able to grow from this psychologically or emotionally or in many other ways. And the biggest challenge is that I did a lot of support work in my time after the first bleed. I did a lot of work for the Stroke Foundation here in Australia, where we did all of the awareness campaigns. But my anecdotal experience was that the awareness campaigns, and this is not true entirely, but were falling on deaf ears, and the audience that needed to hear them, those awareness campaigns, were not there. When I was presenting, the people who needed to hear how to prevent stroke were not there. So then what was happening, we were discovering that in my interviews, I was discovering people who had had a stroke and were young, like me, in their 20s, 30s, or 40s, even in their 50s, and they were, I'm fine. There's nothing wrong with me. It'll pass. I'll have a headache medication or I'll go to bed and sleep it off. And of course, those people are in the category of, I'm not old enough to have a stroke, so it must not be a stroke. And then the people around them, their family, friends, colleagues, also, there wasn't enough awareness of what stroke is, but they were very easily convinced by the person, even though their instincts told them something's not right with my colleague. They were very easily convinced when the person said, oh no, I'm okay. I'm just going to go lie down. I have a headache. So what you're saying and what I've experienced anecdotally really does align there. And over 300 episodes now, and we're starting to understand that what people, stroke survivors, need is more information. And as we get more information about recovery, people are contacting me going, oh, this is fantastic resource. I didn't know that it was possible to overcome these challenges. And I suppose one of the other issues, doctor, is that when we're treated, I don't know if there's a lot of doctors that share your enthusiasm with regards to the possibility of recovery and overcoming. Why are you so enthusiastic? Why do you believe that we need to be telling people that recovery is possible?
Well, your story is well, thanks for sharing. And it has many important points, and I think we can unpack a few of the things that you just mentioned. So first of all, there are two types of stroke. One of them is the lack of blood flow to the brain, a clot, that is called ischemic in medical terms. That's about 87% of the stroke. And there's brain bleed, there's hemorrhagic stroke, which is the minority of a stroke, and both of them are equally devastating potentially, right? And both of them can present with similar symptoms or stroke symptoms. And I think it's important to go over some of the stroke symptoms, and we can stop here and make this parenthesis and talk about the mnemonics that we have. One of them is the B FAST. B stands for balance, loss of balance, and vertigo and spinning sensation, inability to walk. E stands for eyesight. So sudden blurry vision or vision loss or double vision even. F stands for face drooping. A stands for arm weakness, leg weakness as well. S for speech, inability to speak correctly, slurred speech, unable to find words, unable to read, to write, and T stands for time, time to call 911. So those are the stroke symptoms, and they can happen with both ischemic, lack of blood flow, hemorrhagic, bleeding stroke. And what happened to you was a bleeding stroke. Both types of a stroke need to be identified and treated right away. So let's talk about the more common stroke, which is the ischemic stroke.
How more
Like
common
you
is it?
said,
Sorry,
it's
Doctor.
about in 87%, out of the 100 stroke
Mm,
patients, 87 will have ischemic
wow.
stroke. And in the United States, it's about like 800,000 people per year. It happens every 40 seconds. Someone will have a stroke in the United States, overall stroke. So if we go back to the ischemic stroke, it can also happen to anyone at any age, right? What is different is the cause of a stroke is going to be different across ages. So someone that is 18 can have a stroke. Someone that is 60, 80, 90, 100, they can all have a stroke. The causes can vary a little bit, right? Regardless of the age, they need treatment. The stroke is a treatable condition, like you were saying. And the fact of the matter is that I know you're in Australia, we are in the United States, we are developed, we have great stroke systems. Doesn't happen. Stroke treatment doesn't happen at home. We have to call 911. And although I know that you in your country, you have a lot of people that are not necessarily close to a stroke center. However, I know that the systems work because we have worked and we know doctors from Australia, and I know how they are able to take care of the stroke patients over there. So the more or the most important thing is that people, after they have the symptoms, they call 911 because that starts the triage system and the patients can get to the emergency department where stroke can be treated.
Yeah. We have in the main cities, we have stroke units in the hospitals. And what's really cool is recently some of those hospitals rolled out specific stroke ambulances. And that means if our emergency services, 000, if we call 000 and we request an ambulance and we say, I think that somebody's having a stroke, there is a possibility that they will send the stroke ambulance, which is just an amazing resource. And what I've found is the response time by the medical organizations has been such that it's decreasing the amount of time that it takes to get a suspected stroke patient to hospital. And that I have then heard of stories where people have had a stroke and they are compared to me and some other stroke survivors, people who have had other ischemic strokes, they've been able to have their the cause of their clot removed or treated with TPA, and as a result, have a fantastic outcome. And even though they have some, some deficits or some challenges, that they are far better off than they would have been if they waited a lot longer. Tell me a little bit about the way that you guys can treat somebody who turns up into an emergency department and is having an ischemic stroke.
Mhm.
How how do you go in and support them to improve blood flow or to get blood flow back to the brain?
Yeah, no, absolutely. I'll definitely get to that, but I think I really want to highlight the fact that you're talking about the stroke ambulance. So last time we checked, there were about 40 stroke ambulances in the world. And for the people that are listening, what that means is that there is an ambulance that is definitely more expensive, but it's a bigger ambulance that has a CAT scan inside of the ambulance.
Wow.
And what that means is that the people that are riding on the ambulance, they have the knowledge, the radiological knowledge, they have nice techs, they have people that can draw labs, they have the first line of treatment when indicated, which is TPA, TNK, thrombolytic, and those are clot buster medications. So they are harbored in the ambulance so people can be treated right away. But I have to say that that's the VIP treatment, right? So we do have one. I live in Memphis, Tennessee. We do have one as part of the University of Tennessee. We're doing some research and it really works. And there's good data suggesting that people that ride on the stroke ambulance are treated faster. So we have some experience with that. Now, I want to make sure to the audience that the audience understands that not everyone is going to get the stroke ambulance at their doorstep. And that doesn't matter because, you know, our systems of care are built to treat stroke patients. And what happens is that if I'm having symptoms of a stroke, I call 911 and I forget about stroke mimics, meaning I forget about if this is not a stroke or if this is a stroke. I'm not the doctor, right? If I was a patient, I'm not trying to diagnose myself. All I'm trying to do is to activate the system. The system is activated, great data saying that once the EMS paramedics, they call the hospital where stroke can be treated, saying there's a stroke patient or potential stroke patient coming. Once the patient arrives to the ER, there's a lot of people waiting for this patient to start this triage in the emergency department. First step is to get a CAT scan. Like you suggested, people bleed in the brain, and we could not get the clot buster medications to the people that have bled. So we need to identify ischemic or lack of blood flow, and then we give that medication as soon as we can. The faster, the better. Then we do a special CAT scan that highlights the vessels. And then if the arteries of the brain are blocked, or we identify a big artery that has been blocked, then there's a procedure that is indicated that is called thrombectomy. So physicians like myself, many physicians, we obviously have them in Australia, they go from inside the vessels, a tiny vessel either from the wrist or from the groin, and this is a minimally invasive procedure. This is not open skull or brain surgery. This is inside the vessels. They navigate through the vessels as big pipes, and then we go to the brain, and with devices, we get the clots out. And it's amazing how fast we can do these procedures, how minimally invasive they are, and how much better the patients can get.
Yeah, it is amazing. Is it? Are there some risks to doing that procedure? What are the challenges with doing that procedure? And then clearly we know the benefits. If it goes well, where I've heard a lot of them that have gone well, then we can improve blood flow very, very rapidly. So first question, what are the risks with doing a procedure like that?
Yeah, absolutely. So, and that's a good question. For the benefits, we absolutely know the number needed to treat for patients to get better is 2.6, which is amazing. It's better than any other procedure, even medications in the history of medicine. So the downside of the procedure is minimal. But for example, the procedure uses contrast dye, so patients can get allergy to the contrast dye, and that is treated with medications such as steroids, even Benadryl, anti-allergic medications. Sometimes the procedure is under anesthesia, general anesthesia, so there are some risks related to the anesthesia procedure. Sometimes as we go through the vessels, we can injure some of the vessels we get through. So we can call tear of the vessels, etc. Most of the time that heals itself, or we give an aspirin or medications such as an aspirin to treat them. Sometimes the complications can be devastating. We're trying to get the clots out of the brain that causes bleeding in the brain, etc. This is the minority of the time.
Mm-hmm.
And in fact, if we have a complication, or if we were to encounter a problem, we would try to fix it right away.
If you've had a stroke and you're in recovery, you'll know what a scary and confusing time it can be. You're likely to have a lot of questions going through your mind. Like, how long will it take to recover? Will I actually recover? What things should I avoid in case I make matters worse? Doctors will explain things, but obviously you've never had a stroke before. You probably don't know what questions to ask. If this is you, you may be missing out on doing things that could help speed up your recovery. If you're finding yourself in that situation, stop worrying and head to recoveryafterstroke.com, where you can download a guide that will help you. It's called 7 Questions to Ask Your Doctor About Your Stroke. These 7 questions are the ones Bill wished he'd asked when he was recovering from a stroke. They'll not only help you better understand your condition, they'll help you take a more active role in your recovery. Head to the website now, recoveryafterstroke.com, and download the guide. It's free.
Yeah, I do hear from many patients who have had that procedure and it's gone fantastically well. There's some of my guests who have had some challenges with a little, with some additional complications. All of the people that I've spoken to seem to be grateful that they were able to have the procedure, even though there was a complication, even though there was some other challenge. They were very unwell at the time of the procedure being provided, and as a result of that, the outcome may have been a lot worse if they didn't have the procedure. The challenge is that family members often struggle with these decisions, and I think one of the reasons they struggle is because they may not totally understand how unwell their loved one is, and making decisions like that is difficult. I've even had somebody contact me and say, I think I made the wrong decision about allowing the doctors to intervene in my husband's stroke. And it's like, why would you think that? And it's because he's very unwell now. And I made the decision without thinking about it and all those types of things. But in that particular case, I feel like, and this lady also now feels like, that without an intervention, the outcome may not have been as good as it is now. And this particular stroke survivor has had an amazing recovery, and I've followed him for about 10 years. And even though he may have hemiplegia, he is living an amazing life. He is able to become a member of his community. He's able to participate and go back to work in some capacity. He's become involved in creative outlets, and he's been involved in production of shows and all that kind of stuff. So it seemed very, very bleak at the beginning, and it was, but that type of intervention has allowed him to find a way back into an amazing life, even though it has its challenges and difficulties.
Yeah. And I really want to expand on what you're saying, because it's very important to understand that not every patient is going to be the same. right?
Mm.
So we have different baselines. We function differently. We have other comorbidities. And also we do different things. So for example, someone that drives for a living, a taxi driver, might think that if they were having a stroke that just affects their vision, that's going to be disabling. Versus someone that is retired and is living at home. And it's not like you do not want to see. However, your vision is not going to impair you from make a living. So there are so many aspects into this. This is very interesting. But something that I have to address is that time is brain. And it has been probably the most important factor that we know about stroke treatments. Early interventions are going to favor our patients. There are studies out there. There's a beautiful paper of Dr. Saver talking about the quantification of neuron loss. So, for example, if we were to have a stroke and not get treatment, per every hour of not being treated, we age 3.6 years.
Oh.
Millions of neurons go by. So time is of essence. And I understand where you're coming from. Those are very important, critical decisions. But even the time that a family member takes trying to understand and grasp and get a lot of knowledge about what's going on, that is detrimental to the patient, unfortunately. So in many centers in the United States, and I would like you to share what you guys are doing over there, but we treat thrombectomy as an emergent procedure. Of course, we want to talk to the family, but even if we do not reach out to these family members, we go ahead and we talk to other physicians. And as long as everyone is agreeable, we go ahead and treat the patient. And then we ask questions later, because we know that if we lose the time, there's less likelihood that this patient is going to get better.
Yeah, I like the sound of that. Making the decision to treat the patient, I think in that scenario is very important. According to the stats, nearly 2 million brain cells die every minute a stroke goes untreated. That sounds like a lot of brain cells.
That is a lot of brain cells, a lot of brain cells. And across the board, when we look at treatment with clot buster medications and treatment with thrombectomy, which is the unblocking procedure, we know that time is one of the most important factors. So we really need to act fast, going back to the be fast mnemonic.
Yeah. I like the be fast. In Australia, we don't talk about the be fast so much. We mostly talk about the fast. And I like the be fast because it does add that level of B, loss of balance, and E, loss of eyesight, which which are very common symptoms of stroke. But we seem to focus on all the other ones, which are also important. But I love that Be Fast version is a little more, covers a few more people and perhaps gives a little bit more awareness of what stroke can look like on somebody who's in front of you, whether they're a loved one or somebody or a work colleague. There also seems to be some stroke disparities. Now, there are some communities that are they more likely to have a stroke, or what? Who are those communities, and what are the challenges that they face as above to, and who are the other communities? Like, where's the difference there? What are the disparities?
Right. So absolutely. I am Hispanic. So our community has higher risk of stroke, some types of a stroke. Black people will have more likelihood of having stroke. Could be because of genetics, um, could be because of socioeconomic situations. It's very multifactorial. Higher rates of high blood pressure, higher rates of diabetes in my community, the Hispanic community, and in the Black community. So Asians will have more plaque built up in the brain. So even younger Asians will have stroke more promptly because of this reason. And then access to care, right? So lower socioeconomic status will probably have less access to care, lack of insurance, and many people that would not go to doctors, well, lack of education, but also finances. So they are concerned about the hospital bill, paying for an ambulance, what is it going to cost? And all of those factors will contribute to the socioeconomic and racial disparities in stroke treatment. I have to say that your race, your age, your background does not preclude you from having stroke and does not preclude you from getting treatment. We treat all comers. And again, time is the most important thing because after some time, patients will fall outside of windows, right? So there's a time window for the clot buster medication. There's a time window for the thrombectomy and the unclotting the vessels. So if you fall outside of the time trying to wait out your symptoms, you're not gonna get treated.
Yeah. Um, Dr. Inoa, in those communities, is it that there isn't enough awareness about the fact that if you belong to a particular uh, group of people, that you're more likely to have a stroke, and therefore, when you see somebody, you might suspect a stroke more quickly? But why is it that not only will, say, Black communities and Hispanic communities and Asian communities be at greater risk of stroke, um, but is it that they also are not taking action to, um, are those communities not educated about that higher risk and therefore making decisions that are money based or making decisions that are culturally based about doctors or anything like that? What other things are happening in that space that stops people from getting treatment from those communities?
I can tell you, and obviously I would not want to generalize because there is education across the board, but definitely lack of education plays a big factor. And obviously lack of awareness, lack of getting appropriate medical care, lack of identifying the symptoms, not going to the hospital, not calling 911. So, for example, we live in Connecticut. Excuse me, we live in Memphis, Tennessee. I don't know. I trained in Connecticut, so it came up to me. But I live in Memphis, Tennessee, in the south of the United States, under the stroke belt, and in reporting data is mandated by the state, from the different hospitals. And you cannot imagine the majority of people will drive, through these rural areas to try to get to the hospital to get treatment for a stroke. And that is just lack of awareness and knowledge. Because if they only knew different, they would call 911. And I mean, there's a big taboo as well. In my Dominican community, for example, if you got a stroke, you're done.
Yeah.
There's There's nothing afterwards. That is the cultural belief, which is, as you know, it's just absolutely not true.
Mm. It's interesting that thing you said about people drive. Now, I know a lot of people who have said they've driven to hospital to avoid a hospital bill or an ambulance bill. And I totally get it in that moment. Firstly, you don't think you're having a stroke. Secondly, you know that the bill's going to be expensive. You'd like to avoid that if possible. But during that drive, you're missing the opportunity to be treated by an EMT. So even if it's not a stroke ambulance, which it most likely won't be, um, you're still missing the opportunity to get treated and be cared for, and for tests to be done and things to be determined so that they can be reported to the ER, so that when you arrive there, action can be taken in an appropriate way. And also, you're putting other people at risk by driving, because if the stroke that we're experiencing gets worse, it could mean that we end up having a collision, making it worse for ourselves and making it worse for other people around us.
Yeah, and I have met people that get to the hospital and they spend hours waiting in the ER just to get triaged. Let's say your stroke symptom is a little bit of numbness in one arm. And let's say it's the eyesight, it's the vision. Oh, blurred vision. That can be about anything.
Mm.
However, no, it can end up being a big stroke. And sometimes there's a prodrome. You start with milder symptoms. Milder symptoms can be also associated to large clots, right? So things can get worse, etc. So the acute care and the diagnosis are absolutely important. And yeah, I'm completely against to driving to the hospital because of all of the reasons that you just expressed.
Yeah. With the scenario of an ischemic stroke, thrombectomy and medications are really great interventions. How do doctors support people who are having a hemorrhagic stroke? What are some of the interventions that can help decrease blood loss and blood entering the brain?
The best intervention is the diagnosis and the lowering of the blood pressure. And that needs to be done hyperacutely. So there's great data that we know suggesting that or demonstrating that controlling that blood pressure aggressively immediately after the bleed will decrease disability, will decrease rates of death, right? So rapid approach to the acute management of the patients. Patients with bleed, they come in and they can be very sick, so they cannot protect airways. Sometimes they are altered. So protecting, the ABCs of medicine, right? Making sure that the patients are stable, that the blood pressure is adequately controlled, and also getting, in many cases, a CAT scan of the vessels, a CTA, is very important, because depending on the age and the type of the bleeding, people can have brain aneurysms, vascular malformations, and those things need to be treated. So it's equally important that people with hemorrhagic stroke arrive to the emergency department as soon as possible as well.
Yeah. And of course, when you're a patient, you won't know if you're having a hemorrhagic stroke or an ischemic stroke, but the symptoms are very similar. All the things that we experience are the same. So it's just as important to take action, and don't worry about what you think is happening. Just take action because of what is actually happening, what you notice. I'm curious, Dr. Inoa, what in the whole process when do neurologists become involved? So initially, I imagine the first phone call, 911 in America or 000 in Australia, you deal with an ambulance. The ambulance takes you to the ER. And then from the ER, you might get a CAT scan. You might get admitted to a ward. What part of the process does the neurologist become involved in the patient, and what type of role does a neurologist play?
So that is a great question because it's going to depend on the type of hospital that you get to. And in the United States, we have highest level would be a comprehensive stroke center. We have primary stroke centers. We have stroke-ready hospitals. And depending on the staff and the availability of stroke treatments, then we classify these hospitals. A stroke neurologist or a neurologist is not going to be everywhere, but definitely will be at the comprehensive stroke center and the primary stroke center. So it is more likely that in the majority of the hospitals, you're going to be seen, triaged, and treated by the emergency department. So they are capable and they know all of the stroke protocols. And also, they know how to quantify strokes and they know when to refer. So part of the triage system that we have, and I think that's, I cannot be more repetitive. We need to call 911 is because the ambulance, the EMS providers, they will know where stroke is treated and where the specialists are going to be. And for example, if they identify someone that is having stroke or symptoms of, let's say, a large vessel stroke, right? They will more likely route that patient where there's a neurologist, where there's a neuro-interventionalist, where the people can get CAT scans of the vessels, advanced neuroimaging, there's a neuro ICU, etc. Usually where neurologists work, they usually become part of a triage of a stroke as soon as the patient arrives to the emergency department, which is something that probably that's where you were going to, right? You don't have to wait. Once you come to the ER with the stroke symptom, the neurology is literally waiting for you, or someone that belongs to the neurology service triaging stroke patients will be waiting for you.
Yeah, and most importantly, what you said was that everyone you deal with is going to be in a position to diagnose, treat, support somebody who's having a stroke that presents to the ER. So from EMTs to paramedics to registrar nurses to every single person who you're going to come across is aware of the stroke protocol. I really appreciate your time. What are some of the last few messages we can give to people who are listening?
Absolutely. So, well, thanks for the opportunity. I think this really matters anywhere we are. And thank you for sharing your story. And I think it's extremely important what you're doing. And I'm glad to see you talk and, process everything and being great, because that is a great example. I think the final message is probably a long one. Stroke can happen to you and any of your family members, regardless of your background or your age. The stroke is treatable. It is survivable. And I think we are blessed in your country and in the country I live in that we have access to treatment. So we need to understand, to identify stroke symptoms, to call 911, to get the treatment. And again, we are blessed with systems of care that will support the stroke patients and will make their lives hopefully back to their baseline, and their lives can be better or the same as they were before.
Yeah, I completely agree with that. I have definitely some deficits, left side numbness and proprioception issues and a whole bunch of stuff, but things improved, things are getting better. I'm an example of that. The 300 other people that I've interviewed are an example of recovery and the possibility of recovery. Everyone is fighting the good fight, and they are going after recovery. They're being great examples of what's possible. It's definitely possible because of amazing people like you. Without amazing people like you and all the people that work with you and around you, we wouldn't be here. So we are grateful. And thank you so much for your time. I wish you all the best.
I appreciate it. Thank you.
Thanks for tuning in to today's episode. For more insights into our guests and access to a transcript of the entire interview, head over to recoveryafterstroke.com/episodes. And to all those who have shared feedback, your reviews mean the world. They not only fuel this podcast, but also light the way for others on their stroke recovery journey. If you haven't left a review yet, why not share your thoughts on iTunes or Spotify? And if you're watching on YouTube, drop a comment below, give this episode a thumbs up, and hit the subscribe for more updates. To all stroke survivors out there, your story is welcome here. Raw and unfiltered, your journey has the power to inspire and uplift others facing similar challenges. And for those offering innovative products or services for stroke survivors, let's talk about collaborating on a sponsored episode of the show. Just head to recoveryafterstroke.com/contact to start the conversation. Thank you once again for your presence and support. Together we navigate the journey of recovery one episode at a time. Until the next time, take care and stay resilient.
Importantly, we present many podcasts designed to give you an insight and understanding into the experiences of other individuals. Opinions and treatment protocols discussed during any podcast are the individual's own experience, and we do not necessarily share the same opinion, nor do we recommend any treatment protocol discussed. All content on this website and any linked blog, podcast, or video material controlled this website or content is created and produced for informational purposes only and is largely based on the personal experience of Bill Gasiamis. The content is intended to complement your medical treatment and support healing. It is not intended to be a substitute for professional medical advice and should not be relied on as health advice. The information is general and may not be suitable for your personal injuries, circumstances, or health objectives. Do not use our content as a standalone resource to diagnose, treat, cure, or prevent any disease for therapeutic purposes or as a substitute for the advice of a health professional. Never delay seeking advice or disregard the advice of a medical professional, your doctor, or your rehabilitation program based on our content. If you have any questions or concerns about your health or medical condition, please seek guidance from a doctor or other medical professional. If you are experiencing a health emergency or think you might be, call 000 if in Australia, or your local emergency number immediately for emergency assistance, or go to the nearest hospital emergency department. Medical information changes constantly. While we aim to provide current, quality information in our content, we do not provide any guarantees and assume no legal liability or responsibility for the accuracy, currency, or completeness of the content. If you choose to rely on any information within our content, you do so solely at your own risk. We are careful with links we provide. However, third-party links from our website are followed at your own risk, and we are not responsible for any information you find there.